Hello, and welcome to the AMA's Steps Forward podcast series. We'll hear from healthcare leaders nationwide about real-world solutions to the challenges that practices are confronting today. Solutions that help put the joy back into medicine. AMA's Steps Forward program is open access and free to all at stepsforward.org.
Hello, and welcome to this episode in the AMA Steps Forward podcast series. This is your host, Dr. Kevin Hopkins. I'm a family medicine physician and senior physician advisor here at the AMA. If you could change one thing about how medical care is delivered tomorrow, what would you choose? Would spending less time and effort on writing notes be near the top of that list? When I started in practice more than 20 years ago now, it was my first experience with an electronic medical record. Full disclosure, I'm not a good typist, and I didn't have really much interest at all in learning how to do it better. I often thought about how much I would love my job if I didn't have to spend time writing notes. Many people have tried to build the perfect note templates that are adaptable to being used for a wide range of acute complaints and chronic conditions, with lots of links that pull data in from other parts of the EMR. This has led, in part, to increasing length and redundancy and decreasing relevance of clinical documentation. We've tried in-person and virtual scribes to get our notes done, and still, many of us spend an hour or more each evening getting charts closed. AI products promise to cut our documentation time, but they're still new and in many cases prohibitively expensive to be universally available. Today, I'm joined by our guests, Dr. Peter Kleinschmidt, an internist and clinical informaticist at University of Wisconsin, and Dr. Heidi Twedt, clinical informaticist and internist and program director for the Clinical Informatics Fellowship at UW. Thank you both for joining us today.
Thanks for having us.
So we're going to be discussing the work that's been done by the two of you and your team at UW to help physicians spend less time writing notes by implementing a standardized progress note template. But before we dive into that, would each of you just mind telling our listeners a little about yourselves and your background? Dr. Tweet, you want to go first?
Sure. So I have been a general internist, primarily in clinic practice, since leaving residency. And then when my organization, which at the time was Medicare Health System in Fargo, North Dakota, wanted a chief medical information officer, I leapt at the chance to take on that role because I saw great potential in the electronic health record, but knew we weren't quite there yet. I came to UW a few years ago with the goal to move to a new organization and spend more time with teaching and helping to raise the next generation of informaticists.
Awesome. A high calling indeed. Peter, how about you and your background?
Certainly, yeah. So I spent pretty much all of my time here at the University of Wisconsin, came here for undergrad and did my med school and residency, and eventually got into practice in primary care. And really, through all phases of that, I've always just been driven by this goal to not only make things better, but stop doing things that waste time. I love medicine, but I love other parts of my life too, and I want to be able to maximize my time in both places. So that really led me to a career in clinical informatics, because this is an opportunity where you can use existing and new technologies to make the practice of medicine and the delivery of care more effective, more efficient, and hopefully more fulfilling for everyone. I've been doing this for about 6 years now, and I love it, and I'm excited to talk more about it today.
So a lot of what you both just said, I think, is going to resonate with a lot of our listeners. And how a career in medicine has changed. It wasn't all that long ago that when you were a doctor, that sort of defined who you were. And now, less and less that's the case. It's more what we do, but it's not necessarily who we are. We know that documentation burden weighs heavy on our healthcare system and on physicians especially. But just how big is this problem in your view?
So this has been a growing problem for many years, and I think it really has been driven by a lot of things that existed when the health record wasn't the state it is in today. But as a side product of having this ability to, as you noted at the top, pull in all the kinds of information that you could ever need in a note, has allowed us to perhaps grow our documentation in ways that don't really add value. There's a great publication from a few years ago in the Annals of Internal Medicine that showed the differences in documentation length in the United States versus other parts of the world, all using an Epic platform. So the same technology, and the notes in the United States are 4 times longer than they are elsewhere. And that trend has actually continued on since that publication. We continue to see that growth in note length. Actually, a colleague of ours who has done a lot of work on this project, we're going to talk about, Adam Rule, put out a paper that showed that over half of the things that end up in notes were copied from something previously. So redundant information really not adding value. It was already in the chart once. So this is a problem that has fed on to itself over really the last decade and more.
And we find in our work a lot of the things that are pulled into a note are there because of sort of a legacy mythology about the things that need to be in your note, whether for best practice of note writing or for coding and billing reasons. So a big part of our work has been getting on the same page as our coding and compliance departments, and then as a team doing a lot of myth busting, both on the coding side of the house and on the provider side of the house about what needs to be in a note.
Mm-hmm. Is that what you think has contributed to led us to where we are? I mean, 4 times as long. Why does that happen, or why did that happen?
One thing that is actually pointed to a lot in this is the billing codes that drove our evaluation and management system. Those were codes that were published in 1995, 1997, and they were really driven by this idea of sort of a checklist or counting items. And along with that, a lot of things got included into that sort of mythology or expectation of what must go into a note without really much consideration of whether or not it adds value. We had a gift given to us, thanks in part to the AMA lobbying for changing of those evaluation and management code practices in 2021. Things changed dramatically, as I hope most people are aware by now, such that you really are getting credit for the work you do and the decision making you pursue, rather than the things that you wrote into your note or did that, again, maybe didn't add value. The interesting thing is that when those coding changes went through, behaviors didn't really change at all. Nate Apathy put out a paper about a year after that showed that the notes kept getting longer after the change, and the time in notes actually kept getting longer as well. And so we recognize that change in policy alone is not enough to drive behavior change. There need to be technological solutions to support that shift in mindset, along with, as Heidi mentioned, all of the other pieces that play into this to help people feel confident that they're doing the right thing still, because that is what, as healthcare providers, that's always what we want to do, is to try to do the right thing. And people thought that was what was necessary, so that's why they kept with their behaviors despite these really major changes that just kind of drifted through unnoticed by many.
Right. So I'm glad you mentioned myth busting. So it seems like an appropriate time to interject a plug for our AMA Debunking Regulatory Myths series of documents that helps to address these types of questions. And we have several in there about documentation and coding requirements. And I'm glad you mentioned the 2021 E&M documentation guidelines that changed, that were meant to address unnecessary documentation and allow us to document only what's medically appropriate and relevant, and bill based on either medical decision making alone or on time spent on the day of the encounter alone. And we would think once that change came into effect, like, we should be throwing a parade, and this should really decrease the size and length of our notes and our time in documentation. But what I just heard you say is that it hasn't. And one of my experiences has been people not knowing about the change and what's required, or maybe just not even thinking about adjusting and updating their note templates that they may have built decades ago.
Right. I think nobody woke up on January 1st, 2021 and said, great, today I'm going to completely change the way I do a large portion of my work. There's a need to kind of push towards a change to encourage people to try something new that we can do at the health system or physician leadership level to help deliver those changes.
We hear this all the time. I know I should make that change, or I know I should update my template, but I just can't find the time to do it. And the reality is that it would probably take them fewer than a minute or two to make some of those changes on their own. But we like our habits. We like the things that we know, at least we think, work for us. And so in order to help make this change of behavior, our philosophy really is not that we say you must do something, but let's just show you the way that is easier, it's better, make it ridiculously simple, and hopefully people will find their way to you without, again, having to strong arm anyone to make changes.
So what actually led to this change at University of Wisconsin? I mean, how did you come to the conclusion that, Let's rethink and redesign the standard office visit note template. What led you to that?
I think knowing that behavior change is hard led us to think we need to lead this change. So we gathered a group of physician informaticists, coding and compliance leaders, clinical documentation improvement specialists, and IS specialists and analysts to look at our current state of our notes and say, how can we use the functionality of the system to get to a better place together? And as we've kind of alluded to, a lot of that was not about the technical build of a note. We did spend time looking at that, but much more of the time was spent in conversation about what is best practice. Do we need a review of systems in our note? Do you need a physical exam in every note? How do you document your medical decision making, etc.? It was those getting all of us leaders on the same page about those decisions was the real work, because then we have a sort of unified front. We all agree, so we know what best practice is. So whether a coder has a question about best practice or a physician has a question about best practice, we're all giving the same answer. And that is the most powerful thing we did.
The other thing I will say to this is UW is a member of the Arch Collaborative, and so we did the survey offered by class to get interest in what providers want to change about the electronic health record. And we asked them specifically, if there are 3 things you could fix in your EHR tomorrow, what would you fix? And I love that you said your story at the beginning here, because it was exactly what we saw from our providers. Notes was at the top of the list, along with things like interoperability and making it easier to enter orders, which we're not surprised by either. But this is such a huge part of people's work that they're asking for change, but then at the same time having a hard time making the change. So again, getting this team together to support the work and provide a package that is going to be easy to use was really what drove all of this.
Yeah, and they specifically called out, we want all the notes to look and feel the same, because it's a lot of cognitive burden to be scrolling through. If everyone's note looks different, there's a lot of cognitive burden to scrolling through other people's notes, or even your own historic note, trying to find the relevant clinical information if it's buried amongst a lot of things that have been pulled in.
And so that brings us to a really great point, which is really our part of our template, getting into a little bit of the details, was adopting the APSO format. So that's, the classic SOAP note, subjective, objective, assessment, plan. We bring the assessment and plan to the top, because the reality is that's really what just about everyone cares about. Certainly when I'm reading my note, I want to see what I did last time. But we actually find out that the patients want that too. They don't want to reread your telling of their story. If they want to know what was your plan, what do I need to do to follow up on this visit? So having the assessment at the top helps them as well.
So the first thing you did was change the formatting, change the order. And did you get any pushback from that, or was there any resistance to that within your system?
I'll own that I was resistant to the change initially, because in my mind, again, I was in that sort of, my workflow is the way that it must be. And I write my note with the history first. So certainly that's what should happen first. It's the first thing that happens in the room. As soon as I made the change, I never wanted to go back.
Yeah, I mean, I'm sure you had to do a lot of change management. Even getting physicians especially to agree on any one thing is nearly impossible, right? You get 10 docs in a room and you're going to have at least 15 opinions about something. So how did you navigate that as far as a change management piece from the get-go?
We started with a pilot in our general internal medicine group, and then we're able to show, and family medicine, I should say, and we're able to show some wins there, some time savings. We used that data to spread the note to other parts of the organization.
Yeah, truly. At the beginning of this, it was just showing a subset of people, actually just showing my own notes. And for me to show them that I was writing my notes a minute less per note, actually more than that at the time, and cutting down thousands of characters, it got people's attention. And so then we ran that circle again once we got a few more people on board and showed the entire division and the impacts that was having, and brought it over to family medicine and kind of played on their, almost play on their jealousy to say, hey, look at how much better things are here. You guys want to do this too? Let's talk about it. And then when people come to us and talk about the things that they think they need to have in the note, that's when we have that same conversation of, well, do you really? Here's our very simplified template. And we didn't go into too many of the details of this, but it's like 8 lines, maybe 9 or 10 lines. There's not a lot to it, because the point is the skeleton really captures what you need to be doing. And if there's some special things you really need, like if you're a dermatologist and every single time you're going to talk about their Fitzpatrick skin type, sure, we'll give you a little custom line that fills that in. But by and large, people can actually all function within a pretty similar setting, and we really just try to challenge people when they ask for specific things that, again, may not be as value adding and may be more just sort of a vestige of those old habits.
I think another carrot to come to our standard note is some of the regulatory things that we pull in. So, for instance, we have a phrase that you have to say in your note if it is a telemedicine visit. So, we're able to build the note such that it knows that you're in a telemedicine visit, and that phrase is just automatically pulled in. And we sort of can then guarantee that if the wording of that phrase needs to change 2 years from now, we'll just change it for you. And you don't need to keep track of that sort of regulatory content. We'll bring that to you, and you just focus on the medicine.
Yeah, that's great, because a lot of people are trying to remember those smart phrases. I want to get to a little bit more of the specifics of the content of the note in a second, but I think it's important to call out that sort of adoption was optional rather than mandatory from the beginning, which I think is a key change management strategy. And I loved what you said, Peter, that basically the key to engaging other folks was to demonstrate success. I had a similar example here in Cleveland years ago when I did a team-based care model where I had 2 medical assistants that were doing in-room real-time documentation support with me. And people said, oh, I don't think I want to do that. But when they saw me leaving at the end of the day at a reasonable time with all my charts closed, all of a sudden they were like, I want some of that, right? So it sounds like you had the same experience.
100%. And we actually also got the support from the leadership here, which I think is critical, because it wasn't just me saying it, was my division head and the chair of medicine and actually the chief medical officer of the organization all saying the same thing, which is, hey, look at the standard note that's being used. You should really try this. It's going to help you. And so, again, not saying you must do it, but hey, there's something good happening. You should want a part of this.
So I heard you talk about those regulatory key documentation phrases. Other than that, how did you decide what was in and what was out of this note template, and what did it ultimately look like?
So we were doing this in the wake of the 2021 regulation changes. And so we really looked to that as one of our guiding principles. And then we looked to really note bloat and what's helpful information, what's unique to this visit, and what's just being pulled in from somewhere else that's unnecessary. So really it is just assessment plan at the top, and then history of the present illness. And then there's a spot for physical exam, but no required element for physical exam. And then the regulatory things that pull in when needed.
And the physical exam part, to your question earlier, that's one that we got a lot of questions on, which is, well, I need my whole template there. And again, the question is, well, do you need to be doing a full head to toe exam on every patient you see? And yes, sometimes you should. And let's have a pre-built template, give you a speed button that you can pull that into your note when you're doing that. But reassess again what parts are important and what parts are adding value, again, for you, for the readers, for the patient, all of those things. The key to this is just asking the question, really? Like if someone says, hey, I need that in my note, you say, really? Tell me more. What is it really that you're afraid of losing there? And we did this over the course of more meetings than I would have thought to get the template that we did. But each time we kind of took something that was built into the standard practice and said, does it really need to be in there? Examples like, well, I really love to bring the medication list in. Well, it's right there in the chart. Well, how do I know what the medication list was that day? Well, here's actually the tool that does that for you. And by the way, that's going to be the most accurate source of truth because it's baked into the record and it's not subject to any sort of things getting carried through that were not accurate. It was copied from the wrong day. It has, missingness of information. We avoid all those things and actually show that, those practices maybe are worse. They're maybe less safe. They're maybe less accurate because they're subject to human error when you're bringing them in just based off of timestamps and, the provenance where it comes from can be questionable.
Yeah, absolutely. You mentioned the history, present illness, and the spot for the physical. Is any of that pre-populated or templated, or is it literally just free text because we want to keep it minimal?
We have a simple lead-in that is just the patient's name is an age here for star, triple star, because that sort of sets the stage. But that's it for the history of present illness. Again, if there are specific things that you like to do with a specific visit type, we show you the tools to have that built in using in Epic, it's called Note Writer, which allows you to use forms to kind of document these things. But there are lots of different ways that you can support that. But yeah, so a little lead in. It's not just a complete blank slate, but helps get the ball rolling without, again, bloating it too much.
Okay. So at this stage, has the adoption of use been fairly universal, or are there still some holdouts?
We're happy with the adoption. I'd love to see more. We had an uptick over the first year and hit about 40% who are just using our template. So kind of directly from it, using kind of some tricks with analysis, we can see that people have sort of taken the spirit of our note. And there, I guess we've got another 10% who are doing almost exactly the same thing, but maybe they did drop in their own exam that they really love and that we couldn't convince them along with. I will say then the harder thing for us to study just right now is some of the bigger philosophical things, like just adopting the APSO format, like just not pulling in the pre-templated medical history, medication list, social history, everything like that on those. Those, again, I don't have the numbers for it, but I will say just on the feel of things, we've been able to have that change as well. But yeah, we're getting close to, I would say, 50% who are really following our template in primary care.
Okay, so then here's the big question: has it made any difference? How have you measured the impact of this change, and what have you seen?
Yeah, so there are two data points that we can point to that show the effectiveness of this project. The first is note length. Again, we're trying to reduce note bloat, and our success there speaks really well. We see a reduction in character length of about 1,000 characters per note. And again, that's among all comers. There's some variability to that, but yeah, 1,000 characters per note. The interesting thing is, we've talked about slashing out a lot of things that are auto-generated text, so you wouldn't maybe necessarily expect a huge impact on note writing if we're just getting rid of bloat. But people actually do write more succinct notes, and they're in everything else that they're manually putting in, and we see about a minute in reduction of note time. When we say that, some people kind of shrug their shoulders like, oh, it's a minute. But if you figure that's a minute per note per day, and you're thinking 15, 20 patients, that's 20 more minutes back in your life. Again, things that can be spent focused on more on other parts of the clinical encounter. So
You're right. On the surface, it sounds like, oh, that's not very much, but certainly when you scale it across an entire workday or a work week, it's significant. Like doing some quick math, a full-time physician, you scale that, we're talking about like 60 to 70 hours per year. When you add that up, that you could spend doing something else. Any other last thoughts, things that you want to make sure that our audience knows about the work that's been done here, or what you have planned on the horizon next?
The thing that I would most like us to talk about as an entire group of physicians across the country is what is a good note. I think we have sort of legacy thinking about that from the 95 and 97 coding regulations, and we've sort of been teaching to the test ever since then. And now we have a time where we can reconsider what makes a good note.
Yeah. Dr. Peter Kleinschmidt and Dr. Heidi Twedt from the University of Wisconsin have been our guests. Thank you so much to both of you for sharing the important work that your team has undertaken to help reduce documentation burden. And to all of our listeners, thank you for listening to this AMA Steps Forward podcast. Until next time, stay well.
Thank you for listening to this episode from the AMA's Steps Forward podcast series. AMA's Steps Forward program is open access and free to all at stepsforward.org. Steps Forward can help put the joy back into medicine by offering real-world solutions to the challenges that your practice is confronting today. We look forward to you joining us next time on the AMA's Steps Forward podcast series. stepsforward.org.